Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Hello everyone, thank you for joining us for today's webinar, Prepare for Success with Medicare's new 2021 Home Health Billing Requirements. My name is Cully and I'm on the product marketing team. Axxess is a leading technology company offering a complete suite of easy-to-use, innovative software solutions, empowering home health, home care, and hospice providers to grow their business while making lives better. Joining us today are Tammy Ross and Sophia Saldivar. Tammy is the Senior Vice President of Professional Services at Axxess. She leads a team of professionals whose goal it is to provide education as well as practical operational solutions to home health, hospice, and home care organizations. Tammy has 30 years of home health experience and has served as a senior executive of a large national home health agency. Unfortunately, due to a family emergency, expert David Hoover, our Vice President of Revenue Cycle Management, will not be able to join us. However, Sophia works closely with David's team, which to date has processed more than $14 billion in Medicare and managed care claims. Sophia will be assisting today as a moderator and presenter and helping to answer our billing questions. As a home health product analyst, her current responsibilities include using market research and data analytics for planning, developing, implementing, and evaluating our innovative software features. Prior to joining Axxess, Sophia served in a variety of roles, including as a biller, administrator, consultant, and chief financial officer in the home health industry for over 10 years. Thank you both for joining us today. For our agenda, we will begin with a quick overview of the 2021 billing changes. A full overview of the changes is available as an on-demand recording, and that link will be sent to all registrants in our follow-up email along with this recording and these slides. Those slides are also available for download in the GoToWebinar handouts section right now. Following the overview, we will go through frequently asked questions submitted by our audience pre-webinar. Please note that everyone is currently muted, but you may submit questions through the questions box function. Now I'll pass it to Sophia to kick us off with our first of 3 polls we will be having today.
Good afternoon, everyone. Our poll today is, on average, how many days does your organization take to submit a RAP? I'll go ahead and give you all a few seconds to go ahead and answer this question. And it's really to see if you have an understanding right now or a gauge of how long it's taking for you to submit those RAPs, as Tammy has a conversation over our operational practices.
Sophia, while we're waiting on that, I would just like the audience to know that we have over 1,100 registered attendees today. So we know that this RAP and final rule and everything that's coming up in January is on everybody's minds now. So I'm really excited for us to be presenting this webinar and kind of hear the questions that come from the audience today. All right, let's get started then. Exciting stuff to do. So let's kind of go over basically what PPS it was. That hasn't been that long ago. It feels like forever ago. And revenue cycle management. Basically, we used a RAP to kind of establish a home health episode in the common working file. Remember back then we had 60-day periods, only one RAP, one final. That seems like a long time ago. Our initial episode was split 60-40. And our subsequent episodes were split 50-50. So in order to RAP back in the PPS days, you had to complete your OASIS, you had to have physician's orders received, you had to have your plan of care sent, and your first visit completed, your first billable visit. Well, then we rocked on and we got into PDGM. It's only been a year under PDGM, but we knew in PDGM this was just the beginning of things to come. But PDGM started the 30-day periods. Those are 30-day billing periods, and we're still in a 60-day episode. Our RAP is still used to establish that home health episode, but now instead of having a 60-40 split, we went to a 20-80 split. And I have to say, I'm really surprised at how well our industry solutioned for that. It did not cause the downfall of home health like many people predicted. We were actually able to solution through that actually quite nicely. The primary diagnosis can change in the second period of care. We call that a change of focus or a change of care. which would affect your reimbursement for that second 30 days. So in PDGM, our RAP submission requirements pretty much the same. OASIS had to be completed in that first 30 days. The physician's orders had to be received in that first 30 days. The plan of care had to be developed and sent to the physician. And that first visit had to be completed in both periods. I'll say that some of the intermediaries were a little bit more lax on that than others, but for the most part, we had to still have that first billable visit. So that was a little tricky for us operationally, having to figure out that first billable visit for that second 30 days as well. So let's look at what's coming in 2021 and even beyond 2021. How's the RAP going to be used? It's still going to be used to establish a period of care. However, there's going to be no split percentage payments. Basically, it's all going to be on the back end. There's going to be non-timely submission penalties. RAPs accepted in the common working file, they have to be accepted. I want you to kind of underline that word and keep that in your head. It's not when you submit, it's when it's accepted. And we know there can be delays in it being accepted, 24, maybe even 48 hours. 5 days from the initial start of care. So start of care counts as day 0, and then you start counting from there 1 through 5. 5 days from start of second period as well for your second RAP. There is a 1/130th reduction. We call that the RAP penalty for every day you're past that 5th day. And there's no LUPA payment before prior to the RAP being submitted. So if you have visits and you're late on your RAP, we'll see how this can impact it. You could lose the majority of your reimbursement. And in January 2022, the RAP's actually going to be replaced by a notice of admission. This is very similar to what hospice does now. In fact, they've had that for quite some time, the NOA. We give you some sites there that you can refer to later. And I would encourage you to go on those links that goes into much more detail than I'm able to do in this brief overview. I love this graphic that David Hoover, our VP for Revenue Cycle, put together for us, because I think it's just a really good picture of what's happening. If you see in that graphic under PPS, you can see the start of care side is heavy and the start of care is blue all the way over. We got very little on that back end. But then once we go to PDGM, we can see that revenue shifts. And then from there, you can also see that coming forward, 2021, it's all on the back end. So that's going to make a little bit of a change for what we're doing now. Good thing, there's no more rejected RAPs. There's going to be reduced posting. Submission requirements are reduced. So that's all a good thing. If we can avoid those penalties and those revenue reductions, we've got this handled. So late RAP submission penalties, let's talk a little bit about that. After the 5th day of the period of care, the episodic payment is reduced by 1/130th. So if you kind of think about that, that's about 17% of the episode if you hit into day 6. And then 7th is even more, and it just goes on and on, right? You could lose half or even more depending on how late your RAP is actually submitted and accepted. For LUPA payment adjustment, if the claim is identified as a LUPA and the RAP's not submitted timely, visits conducted prior to submission, not reimbursed. So you lose the whole amount of that LUPA, which could be significant because we're already losing on LUPAs anyways. So Sophia, it looks like it's time for another poll after we've given some of those facts about RAPs.
Yes, I love it. Let's go ahead and get this poll started. So our next question is, how operationally prepared do you feel your organization is to avoid penalties and adjust to the upcoming regulatory changes? So let's go ahead and get those answers in. Are we not prepared at all, somewhat prepared, almost fully prepared, 100% prepared, or we've already implemented some changes or all changes needed to be prepared?
This was going to be interesting, Sophia. I can't wait.
Absolutely. We've got a lot. Yeah, we've got a really good percentage so far. Over 60% of our attendees are saying that they're somewhat prepared. So this is great. This is good to know that everybody is being very proactive in terms of preparing for these changes.
All right, let's talk a little bit more about some operational issues as our poll closes out. Thank you for participating in the poll. So if I was sitting on your side listening to this webinar, I would be thinking now, how am I going to monitor the wrap countdown? I need a way to be able to see when that wrap is aging, right? So I can make sure that I catch it before it hits that day 5. How am I going to ensure that I meet the guidelines for submitting a wrap? How am I going to manage those LUPAs? Because now it becomes even more important because I could lose all my revenue. And we know that that very first visit is the most labor intensive and usually costs us the most, right? So you don't want to lose that start of care visit and not get revenue for it. What adjustments should be considered in reporting? If I have penalties, how am I going to account for that for end of the month reporting? How is that going to affect my budget? How is technology going to play a role? What can technology do to help me? What is my vendor doing currently for it? And I'm sure some of you are thinking, what about coding? How is that going to affect my operations? Should we pre-code? Should we not pre-code? These are all items that I'm sure we're going to be discussing more in the FAQs, but let's go through a few of them now. So directly from CMS, requirements for wraps have really been loosened. The appropriate physician's written or verbal order that sets out the services required for the initial visit has been received and documented. Let's think about that. Do you think that a referral that comes over that says assess and admit for home care meets that criteria? I say no. I don't think that's going to cut it. So we have some education to do with our physicians and with our staff and with our intake department. I know some of our organizations are even looking at templates for their referrals that would make sure that that case manager or that physician documents what services, OT, PT, ST, skilled nursing, home health aid, all of that needs to be on there. The initial visit within the 60-day certification period has been made and the individual is admitted to home care. Now, being an operator for over 30 years now, I know that sometimes we get very confused with OASIS and a skilled visit. OASIS is not a skilled visit. OASIS is the assessment, and a lot of times we combine that with our skilled visit. But the skilled visit is what did you do for that patient that made that visit billable? Did you perform teaching? Did you do wound care? Did you set up a therapy program? What did you do to make that a billable visit? Really think about that, because a lot of times it's pretty thin when I review charts that a billable visit was actually made. Timely submission is now being enforced. RAP must be submitted and accepted by the common working file by the 5th calendar day. Must be accepted. And I know Sophia will go more into that. And then also our second billing period RAP can be sent at the beginning. Never can say that word. Sequential billing. Oh, Sophia, help me out. How do you say it?
Sequential.
Thank you. Sequential billing. We don't have to have that. So
right.
I think that's going to help, right? That's going to help operations tremendously. I personally think if it was me, I can't think of any reason you wouldn't do both at the same time, both of your wraps at the same time, but we'll let Sophia, she's the expert, talk about that more in a moment. Operational action items. How are you looking at those late visits and making sure that they're coming in timely? That's going to be important. There's no more 12 days before a visit is completely documented for start of care. By the way, that's the national average, 12 days. That just seems crazy to me. But 12 days, I know my CFO wouldn't allow that, and I'm pretty sure Sophia didn't allow that back in her time when she was CFO either. Perform timely assessments, rehab, start of care, OASIS, performed by the therapist. you know, some of you are still using contract therapists in your organization, and oftentimes you have that nurse go out, you have that therapist go out, or maybe you have that therapist that doesn't turn in their work because they're a contractor. So making sure that rehab performs their own start of care is going to help really cut down those late admissions. And I'm getting a little bit of feedback. I apologize if you guys are hearing that too, but there's just a little feedback in the system here, so apologies for that. 24 hours for assessment documentation, guys, that's the standard. In a hospital, you know, could you leave your documentation for 5 days sitting there? There's no way. And I have to put it back on our profession, our nurses and our therapists. Look at our practice acts. How safe is that for a patient? What if something happened to you? How's that continuity of care going to be carried on? Get those secondary disciplines in as soon as possible. I know for PDGM, a lot of you are wanting that secondary discipline to help collaborate with OASIS. But remember, we don't have to have that OASIS done anymore. It doesn't have to be complete, just that billable visit. Maximize your workflow efficiencies. Make sure that our technology has clinical intelligence so we can go quicker. We being the nurses out in the field or the therapists out in the field, if they can do their work quicker, we're going to do much better. Ensure proper documentation for that verbal order. That's where you're going to have to train intake and your referral sources to look to see that you have that information that you need that will constitute a verbal order. I personally see a probe coming up on that one. I can see that that's going to be an area next year that Medicare is really going to dive into and take a look at that verbal start of care order. Ensure rapid quality assurance to make sure that we have that first billable visit. All very important. As we look at this LUPA impact, we can see here the LUPA rates. We have put the LUPA rates on here, and we can kind of see the impact of having a late RAP submission. Our LUPA SN rate would have been $449.04, and our home health aid would have been $67.78. But because we submitted late, and you can see that on the calendar on the left, our LUPA visit threshold was 6. That's another thing very important. You've got to know what your threshold is. You have to have that visibility. At Axxess, we have that very visible with LUPA thresholds. If your software doesn't, you need to start asking them about what are they going to do to make that LUPA very visible to you. Because look how much money you lost on this one, $516.82. So your payment reduces to $67.78. Not good. So what are you doing to make sure that we wrap on time? First of all, making sure that paperwork is in on time, making sure you have enough staff. Maybe it's time you start looking at supplemental staffing to help you on starter cares so that we can get this process in quicker. So next steps, top 4 considerations in my view is knowledge. Thank you for being here because you've taken that first step. Now you can take this education back and you can educate your staff and your referral sources. Our second one is workflow. Examine what you're doing in your workflow so that you can streamline those processes. Make sure that you are doing appropriate resource management. I mentioned that with staffing. How are you utilizing your staff to the best of their capacities to make it most efficient? How are you scheduling? Is that scheduling visible to you? Some of you have been in home care as long as I have, and you probably remember the notebooks, and we used to highlight our notebooks. The last 5 days when we had to restart them, mine was always marked green. I knew I had to do a research visit in that last 5 days. Now with the wraps, I say we should have something like that as well. You know, we've got to have maybe something that goes from yellow to red in that first 5 days of the wrap. So we know if we're getting closer to the red side, we're in trouble. Orders management, and that's more that intake, that's that initial order. How are you going to manage when you get that referral and it doesn't have the appropriate information? Have a good friend of mine, I hope she's on this call today, Arlene Maxim. Many of you know her. She works with Axxess now. She's actually solutioning, what if we do a standard template order form for those times that we get a referral over that doesn't have the correct information? What if we go ahead and list out the correct information, make it easy for our referral sources? I think she's on to something with that, and I think probably a lot of you will consider doing something very similar. Technology, no-pay wraps, making sure your vendor has no-pay wraps set up. Do they have wrap aging buckets set up on the dashboard? We do. Sophia was a big part of that. We're able to see the wraps aging so we can make quick interventions. How are you solutioning, and how's your software solutioning penalty adjustments? How is that going to look on your financial reports? What's being done for that? How is the workflow being enhanced so you don't get into the penalty to start with? All questions to ask your vendor. And lastly, change management. Guys, change is hard. If you're currently wrapping at 12 days, which is the national standard, how are you going to back that up to get to 5 days by January the 1st? One thing you're going to have to do is make those changes immediately. Educate, give the rationale, start making those changes. Use business intelligence tools to help you see where your problem areas are and where you need to make the change. In addition, expectations. You need to set very strong expectations with your staff at this point. And what's expected is inspected. So if you expect a result, you're going to have to start inspecting it at every step of the way, starting now, and start making those changes now while we have time. And time goes fast. January 1st will be here quick. So just a summary of those changes really quickly. Elimination of the split percentage payment. It's all on the back end now. Penalty for delayed submission of wraps. Revenue reduction of 1/130th per episode per day. You can see you could get down to 0. You could get paid nothing for 30 days if you didn't get your wrap submitted. Reduce wrap submission requirements. We like that. All reimburse paid on the finals, and we talked about that. And then lastly, make those changes now. If we don't start changing now, it's going to be really tough come January 1st. So a lot to think about, nothing to worry about. This is nothing new as far as our operational standards. It's been a part of the COPs. The billing piece is changing, but honestly, guys, we were supposed to have these wraps done in 5 days ever since I can remember, and I've been in home care a long time. So, well, ever since there was wraps anyways. I was in home care before there was wraps and PPS. So let's start making those changes. Let's start thinking about it. Let's don't start worrying about it. Let's just be proactive with those changes. And Sophia, I think we have another poll question.
Does your electronic medical record system have a plan to adjust to the 2021 Medicare home health billing changes? And our answers are yes, no, not applicable, or we use paper, or unknown, or this plan has not been communicated. So let's go ahead and start putting in our answers here.
Awesome. I'm hearing a lot of vendors have not communicated their plan yet, so it'd be really interesting to see what the poll shows on that one.
Here we have our results. So over 50% of our attendees today are saying that their EMR system does have a plan to adjust to the 2021 home health billing changes. So I hope that 59% is a lot of our Axxess clients. As you've seen, and as Tammy just spoke on our wrap aging tool, we're already starting to push out a lot of those changes for these new regulatory changes.
Awesome. That's good news. That's good to hear, and good for our industry that our vendors are prepared. We know Axxess is prepared. So, Sophia, I'd like to ask you a few questions now. I am actually going to come off screen and make you the focus of this and start with a few questions that has came in. Does an OASIS have to be completed in order to bill a RAP?
Currently it does. For 2021, you will not need to complete that OASIS prior to submitting your RAP.
All right, excellent. What about a plan of care? Does a plan of care need to be sent to the physician in order to bill a RAP?
No, it doesn't. So that's the another beauty or positive about this change in 2021. A lot of these requirements, as you discussed earlier, have been loosened. And so one of those is that we no longer need to send that plan of care to the physician prior to submitting the RAP.
Excellent. Does a visit need to be completed in order to bill a RAP?
CMS has clarified that initial visit is required for initial RAP submission, meaning a billable start of care must be completed. However, in regards to recertification episodes and instances where a patient might not be seen in those first 5 calendar days of care, an agency can use the from date of the billing period to serve as the service line date in order to submit the RAP. This will prevent delaying the submission of the RAP for subsequent periods, again, when that first visit in the period is beyond that 5-day time frame for the timely filed RAP.
So, Sophia, can we bill those 2 RAPs at one time, like at the beginning of the episode? I've been being asked that a lot.
Yes, you can. And that's the beauty. Again, that's one of the other positives of this change as we're transitioning over to the NOA in 2022. We are being given the opportunity to bill both the first and second billing period RAPs at the same time. Now, the way that this will work is that the first billable visit will allow for that first RAP to be submitted, and then the second RAP will be submitted alongside that, of course, in a different claim. But what will happen is that the service date that appears on the line item for that 0023 code is going to be the day that that 30-day billing period begins. So it won't necessarily be attached to a first billable visit within that second 30-day period.
Okay, and for those of us that don't know billing, what is that 0223 code? What is that?
Yes, the 0023 code is going to be the identifying code to say that the patient is receiving home health services.
Awesome, great. All right, so here's another one, and I've been being asked this a lot, and I know you and I and David have had many talks about this one. Can a generic HIPS codes be used for the RAP since we don't have the OASIS yet? Can we do that?
Yes, we can, and that's another positive, right, with this change. We can use any generic HIPS code for the RAP submission, and this, again, goes with that same service line item that we have on those RAPs. So in that same line where you have your 0023 code, you also have to identify a HIPS code. This HIPS code now can be a generic code for 2021 since we're already identifying basically that the patient already has services within the home health industry.
And Sophia, and I know I asked you this when we did all of our pre-conference discussion, but because it's coming on the final, that's when your real HIPS code will be applied, or do the two of them have to match up?
They do have to match. The HIPS code for the RAP and the HIPS code for the final do need to match, or DDE will shoot that claim back to us as a return to provider correction. And so it is depending on your EMR. I know here at Axxess, we will be utilizing generic HIPS codes when actual HIPS codes are not available. So if you have nurses or clinicians that are turning in their paperwork lickety split, that's great, and we'll utilize their codes, the HIPS codes that's generated based on their assessments. But if they are not turning them in timely, we will be using generic codes within the RAP that match the final for submission purposes only.
Okay, and then I just want to kind of go just one level deeper on this code and so forth. Do you have a generic code that you would recommend to our audience to use?
Off the top of my head, I would say 1AGKS. I think it's like the first one on the list of codes. But I believe that will also be the code that we're utilizing for Axxess. It's probably why it's so top of mind for me today. But it really is just dependent on what your EMR places there.
Okay, excellent. And I think it's really important that the audience understands that it's really Medicare that is determining our payment, right? So those generic
Right.
codes not going to affect payment in any way, correct?
Correct. So what happens is, and this really started with PDGM. So what happens is our HIPS code gives us as agencies the opportunity to gauge what our expected reimbursement would be per service period, right? However, ultimately, with the submission of our OASIS to the IQ system is what determines our reimbursement. And so even though we are sending that code in, it doesn't necessarily mean that that is what CMS is reimbursing. They will reimburse based on that OASIS submission. And so it is still important that we are sticking to our 30-day timeline to submit those OASIS assessments, because if those are not submitted, then ultimately you will still get your final rejected.
Sophia, that's great. Things are going off in my head right now, just hearing you talk. I think as an operator, as I sit here listening to you, I think it would be very important for me to use like the PDGM modeling tool or some such tool if you're not on Axxess, so that I would know what my reimbursement is, so I could plan my resources. Are you kind of seeing that would be important as well?
Yes, absolutely. And for those agencies and organizations that have reached out prior to, that has been the advice that I've been giving them. Within Axxess, we do have a PDGM modeling tool, which allows for you at onset of receiving some information regarding the patient and the care that they're going to need. It allows for you to kind of pop in those diagnoses, identify whether you feel there might be a low or high comorbidity adjustment, and really be able to gauge and estimate what you will be getting reimbursed for that period of care. Not all EMRs have something like this. This is a tool that we developed while PDGM was starting up last year, or rather this year, right? We're still in 2020 as much as we want to be out of it already. But it is a great tool that is usable, and I think that it's important, like you said, operationally and also for DONs to track as well, to see how much of our employee or our staffing do we want to give to this patient? How can we gauge whether or not we even want to accept this referral, and how much we would get reimbursed versus how much we'll be putting in? So really looking at those profit margins.
Yeah, excellent. And I will say, because I was a big part of that PDGM team last year, and I know the thought process was already there for the no pay wrap when that tool was put in, and kind of utilizing it in just the way that you talked about. I think we all hoped it would go away and wouldn't happen, but it is happening. And the no pay wrap is, certainly here. So last question from our questions that was submitted by our audience before the webinar. Does the wrap need to contain all of the diagnosis for the patient, primary and all secondaries?
The wrap in 2021 will not need to contain all diagnoses. So kind of going on or piggybacking on the no longer needing that OASIS assessment, we won't need a full picture of care for the patient. So long as we have one diagnosis for the patient, and that's the primary listed on the wrap, that is the only information that is necessary as far as diagnoses are concerned. And to add on to that a little bit, because we aren't submitting that OASIS information, we also no longer need value codes 60 or 85. Value code 60 is our CBSA code, and value code 85 is our FIPS code. And so those also determine part of our reimbursement, right? We know this with our urban and rural designations. And so again, that's not going to be required on the claim submission anymore as well.
So does that mean there's not an adjustment for the rural and the urban based on CBSA codes? There
still will be an adjustment, but it will just be, since we're not getting that 20% at the beginning for our wraps anymore, that adjustment will be factored into the final.
Awesome. Well, I know I always learn when I listen to you and David talk. So I appreciate the questions that were sent in, and I suspect we have more questions from our audience.
Please submit questions using the questions box, not the chat box. Sophia will review those and select ones for our question and answer session. If you submitted one of those questions and need further clarification, please raise your hand and we will unmute you so you can ask follow-up. Please ensure that your microphone turns green before you speak. You may need to actually unmute on your end as well. Any questions that we don't get to will receive a follow-up message from our team with answers in the coming days or next week.
All right.
So one of the questions that we received, thank you for that, Cully, by the way. One of the questions that we received was really to clarify the submitted and accepted factor of the 5-day window. So our guidance is that it should be submitted and accepted like it would be for hospice. And the reason that this is our guidance specifically is because we were sitting in on a webinar that was given by Palmetto GBA to a group of the review choice demonstration states. And what they were saying there is, although a RAP is submitted, it doesn't necessarily mean that it has been accepted. So a RAP can be in S status once you submit, and then tomorrow it can turn to a T status or the return to provider status. And so when that happens, your RAP will still be essentially on a time frame, right? So you still have to send it within those first 5 days. However, now it's in return to provider status and the clock is still ticking. So we want to make sure that agencies are going in and ensuring that not only is their RAP submitted, but their RAP has also been accepted by a DDE in the Common Working File. I hope that clears up some of the confusion that is going around, I'm sure. Then there is a question here. If we receive, and this question is from Marcy, and this question is, if we receive a verbal order from an MD to start services, do we need to get that order signed before submitting the RAP?
Okay, so I'll take that, Sophia. No, it's actually a verbal order or a signed order. I will just, again, stress here that that order must contain all of the services that will be providing care. So if you're going to have multiple disciplines involved in that care, that order must list that out. So I hope that answered your question.
Next, we have a question from Joyce, and I think this one will be for you as well, Tammy. What are you seeing in audits that is sketchy for whether or not a start of care is billable?
Yeah, so we're not really seeing a skill, and I think we have to really go back to what a skill visit is. You know, you have 4 levels of skill for a nurse. That's a direct care visit, which would be like an IV, a Foley, a wound care, a teaching visit, which you're teaching medications, you're teaching disease process, you're teaching safety. The third one is an observation and assessment visit. And we know those are only good for 21 days, and you have to have some other guidelines as far as that observation and assessment. It's good for the first 3 weeks. And then the last one is management and evaluation of care plan. We typically don't see that on the start of care. We typically see that in research because there's usually another skill that's going to take priority over an M&E visit. But what I'm seeing oftentimes is our nurses just do an assessment and they only fill out the assessment questions. They don't actually meet the qualification for a skilled billable visit. They're not performing that teaching or that direct skill or an assessment and evaluation visits as Medicare defines it.
This question's coming from Candace, and it says, I have a question about referrals. Sometimes our referrals come from the hospital and we can use that and a face-to-face. Can we use a referral from a nursing home, or do we still need them to see their physicians to get that visit as the face-to-face and referral?
Okay, so face-to-face visits as it relates to coming from a nursing home. So a physician in a nursing home can perform a face-to-face. That's not changing. However, just like a hospital list, a physician from a nursing home is most likely not going to be following and collaborating with that plan of care. So you're going to need that person's PCP or the person that's going to be signing that plan of care to collaborate on that face-to-face. So that's not really changing with the new billing requirements. Again, I'm going to stress here, if it's coming from a nursing home, it's going to need to list all of the services on that referral. If you're going to count that as your start of care order, it's going to need to list all of those services that are going to be received by the patient. Good question. Thanks, Candace.
Thank you for that answer, Tammy. Let's go ahead and look for another question. We have another question here about operations. So let's look at this one really quickly. How many patients, and it comes from Laura, how many patients do you think that RN case managers should manage? This is important because it does relate to the timeliness of documentation and overall compliance. So do you think that there should be some type of shift in this as well?
Wow, that is a great question. So I think it's really going to depend on you looking at how many visits, how many average visits per episode your agency is doing. And a really good place to find that information is the Peppers report. And we know that, you know, less than 50% of agencies actually pull the Peppers report and really dive into that information. I can tell you the intermediaries are pulling that report, though. They're looking at that. They're looking at that as a source to actually find things to survey you on. So know that first. If you have a high utilization, in other words, you're seeing your patients maybe more frequently than the average agency, it's going to affect how many patients one RN or one case manager can manage. Other things are going to affect it as well, whether or not you do team nursing. Whether or not you have someone that's an admission nurse. So there's a ton of variables that go into that. I can tell you now in the PDGM world, most people are sitting somewhere around 25 patients on a caseload. I've seen them as low as 15. So sometimes between 15 and 25, but it really just depends on what type of patients and the skill sets required. If you're all IV patients and it's taking you an hour and a half to infuse an IV, you know, maybe that's going to be too many. So look at your variables, but just know that, you know, probably past 25, you're probably getting into an area where you're going to really have to do some team nursing and maybe use some LVNs to help you.
Great answer. Thank you, Tammy. The next question that we have that we're pulling today, and please be mindful, everybody on the call, we do have a lot of questions coming in, and so those that we don't get to answer on this call, I know we've got about 13 minutes left, but if whatever questions we don't get to answer, we will be following up with you individually, and we will be doing our best to get as many of these questions answered and sent to you as well, with the recording of this webinar and the deck of slides as well. So we're trying as much as we can to get you all of the information that we have as soon as we have it. As you know, as a lot of our billers on this call know, CMS likes to tell us a couple of days before something happens that we're going to have a change. And so as up to the minute as we're getting this information, we'll make sure to relay to you. The next question that we do have, though, is where will Medicare pull the information on the correct HIPS code if it will not be pulled from the UB04 anymore? And so this is a great question. Again, kind of to reiterate, this is where we are making sure that our billing and our clinical are working hand in hand, our billing staff and our clinical staff, to ensure that our OASIS is submitted on time so that we can get that IKey submission sent by our internal staff. And then we can make sure that our claims, when they are in already DDE, have that information to relay reimbursement. So ultimately, reimbursement will come from your OASIS assessment once it's submitted and CMS has an opportunity to review that information. And so that's where those reimbursement amounts will come from, the assessment completed on your OASIS. So it's important that our clinical staff know to be timely, but also that they are very well updated on the newest changes to CMS. I know that we did have some code changes that happened here in October, and so it would be important to continue to provide that clinical education to your staff.
Mm-hmm.
Another question that we have here is, can a diagnosis at the wrap and final be changed? This is a really, really good question, and we actually had this question as well as we started thinking about the changes that we were going to be adding and the features that we were going to modify in our solution. And so we attended as well. We're always learning here too. That seminar that I discussed with you all last week for coming out of Palmetto GBA. And their instruction to us is those diagnoses codes can actually be different. They don't necessarily have to match from the wrap to the final. So that is something to take into account, that maybe you have an idea of an admitting diagnosis and you want to use it on the wrap to get it sent out because the nurse has already completed that visit. But maybe when they're doing their 5-day, within that 5-day window of when they're creating the plan of care, therapy decides that maybe this is more important and maybe we need to have this therapy diagnosis code as our primary, right? That's just a scenario there for you all. But in those cases, you can change that primary diagnosis if you want to, depending on what your EMR will allow, so that it can be appropriate on the final. So we have a couple people that want for us to go over the second billing period and the wrap for the second billing period and how we can send it at the beginning of the 60-day cert. So hopefully we can utilize our imagination as we talk through this scenario, right? And I kind of give you an idea of what's going on. So let's say we had a start of care visit and the start of care was completed today. And our nurse was amazing and they sent us their information on time and we got the right diagnosis information in there. All of the assessment has been completed because they're awesome and that's why they're on our staff. But we now have sent that wrap and that wrap is good to go. But now we're looking at that second 30-day period. We can go ahead and send that second 30-day period, you know, tomorrow or today, even if we already had that information. That second 30-day period what is essentially happening, what essentially is saying is we already know that the patient has been admitted for a 60-day certification period. So we're only utilizing the wrap in the second period essentially to match the final for reimbursement, if you want to think about it that way. And so even if we send the wrap for the second 30-day period at the same time that we send the start of care wrap, then we're okay, because we are identifying that the patient is currently admitted to home health services and that an initial visit has been done within the 60-day period, which is what the requirements will be for 2021. So hopefully that helps to answer everybody's question or to clarify a little bit on how we're able to actually send that second 30-day wrap, even though there's technically not a billable visit for that 30-day period. Again, just to highlight that requirement, it is that a visit needs to be done within, a first billable visit needs to be done within the first 60 days of the care for the patient. So it would qualify as the trigger for us to send that second wrap. And also to reiterate, if in the time that it takes for you, or rather, within the first 30 days, if you identify that you have a change in focus and care, maybe now the patient has wound care, they had a pressure ulcer that is apparent now, and we want to change that diagnosis code, but we've already sent the wrap, that's okay. What we can do is we can cancel the wrap for that second 30-day billing period, change the information and resubmit the wrap if we want to, or we can leave it as is, because the wrap diagnoses and the final diagnoses don't necessarily have to match anymore. We can go ahead and keep chugging along, making sure that our patient is getting taken care of, and ultimately make sure that our OASIS recertification is identifying that our change in focus has happened and that we are putting that complex nursing or wound care diagnosis code at the top of our food chain there.
Yeah, it makes it a lot easier, Sophia. Operationally, it's a lot easier than what we've been doing now. So that we
Absolutely.
can just catch it at the end.
Yes, it's definitely a pro of these changes. We know that 2021 is kind of already looking a little bit scary as far as fillers are concerned, right? And really eating at that 20% reimbursement that we are getting at the beginning. But a lot of these pros or positives to these changes are really going to get us ready to transition more appropriately to the notice of admission that's starting in 2022. And just a little bit on that, we will be here at Axxess, we will be making sure that we start that education on the NOA as soon as more information becomes available other than just the preliminary information that we've been receiving. So please be on the lookout for all of those webinars as well. And tomorrow we actually have a webinar with Mike Carr, who is a really good colleague of ours, but also with a consultant, I believe from Sibian Healthcare Consultants, who will be going over the remainder of this final rule. And so Tammy's and my conversation today is really about the no pay wrap changes, since they are, affecting all of our Medicare certified clients. But there are other contingencies within the final rule that are really important for agencies to see. There's opportunities for more revenue streams. And so when we see that this 20% is kind of being, taken from us at the beginning, we want to make sure that we have other ways to supplement that income coming into agencies and organizations while that full reimbursement is pending from Medicare. So please, if you haven't yet, go ahead and register for that webinar tomorrow, and you can find a link to that at our Axxess LinkedIn page.
Hey, and Sophia, I'll just let you know the other presenter is Charity Farnsworth, and she's actually with Healthcare Consult Link. She's a plus presenter as well, so that should be a really fun webinar.
Thank you, Tammy and Sophia, for sharing your expertise and wisdom with us. Don't forget, we will email everyone a link to the slides and post a video recording of the webinar. By the way, if you haven't checked out the Axxess user community, I encourage you to visit community.axxess.com. It's a great place to share information, ask a question, and connect with other Axxess users to keep learning and growing. Thank you for your time today.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on Software Advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.